massive and rapid inflammation that is encountered by the patients of COVID-19 or SARS-CoV-2 virus. So the interesting thing is this. What we have observed is, unlike the flu, this COVID-19 patients, they very rapidly start deteriorating, and anywhere from 4 days to 14 days, not only they have massive inflammation in their lungs, that inflammation actually starts spreading to the body as well, and then it causes a lot of consolidation in the lung and lots of damage in the lung. So many people have been asking me that, hey, why would this COVID-19 or why would SARS-CoV-2 cause more damage compared to the flu, and they are similar or they're not similar? So I wanted to make sure that we can look at how this rapid damage can occur. So the short answer is that there is a massive inflammation for a few reasons. One of the reasons is that there is ACE2 receptor reduction, which is a inflammation modulating receptor. Second reason is that there is a possibility in some people of cytokine storms, and I'll explain what these are. And the third reason is there is massive production of IL-1, IL-6, and IL-12 tumor necrosis factor by the innate arm of the immune system, which in turn causes massive response in the body, which in turn causes severe inflammation and destruction of the lungs, and not only the lungs, then the body as well. So I wanted to make sure that these 3-4 mechanisms are clear to all of us to understand how rapidly this virus kills and why does it do it, and why we should really, really make sure that we do not come in the way of this virus, and we do not have our loved ones, our friends, our colleagues, all human beings not affected by it, by being a little more careful. So let's start. I'm going to share my screen, and I'm going to show you how these 3 mechanisms, ACE receptor reduction, cytokine production, cytokine storm. Again, cytokine storm doesn't happen in everyone. We do not know the exact reason for why this massive and rapid damage, but these are the possible solutions, mechanisms to this problem. And the third one is massive inflammation. So let's explain those. So good evening, everyone. Thank you very much for joining. Let's look at it. Thank you. Thank you. So let's start. So first of all, a little sober note here. We have almost reached about 1 million. In next 3 days, we would be about 1.4 million. This virus seemed to be causing the spread. In 3 to 4 days, it is doubling the number of people affected. So now we are even worse in our exponential growth. So that is a sobering news. I hope we all stay safe. I hope you stay safe. All your loved ones, your colleagues, and the whole humanity stays safe. Let's work for it to do our part. Having said that, I wanted to share. So when we are talking about the massive inflammation and why this virus kills so fast. So keep this in mind that within 4 to 14 days, the virus not only causes destruction, severe destruction of the lung parenchyma and the lung tissue, but even consolidation and fibrosis is ensued. Fibrosis, consolidation happens. I would also add one more word here, organization of the pneumonia occurs as well. So this is a very rapid, very massive inflammatory response. And I wanted to share with you what could be the reason that this happened. The literature is evolving, the studies are evolving, so I cannot say that this is exactly the right mechanism, but I'll keep giving you the references to where I'm bringing these mechanics from. So the first one is ACE receptors. So look, ACE receptors, ACE2 receptors on the cells, which are present abundantly in the lungs, in the heart, in the kidney, in the GIT. So this virus can actually connect to many of them and cause damage. ACE2 receptors have an important function. So of course, one function is to work with the angiotensin angiotensin. Remember, there is angiotensinogen, and that becomes angiotensin 1 and then angiotensin 2. They work on angiotensin molecule and convert it to angiotensin 1 and 7, or 1 to 7, instead of angiotensin 2. So this is a vasodilator. These molecules are vasodilators. That is why there is septic shock. That is why there is reduction, severe reduction in blood pressure, because on one end, the inflammation is causing the damage to the tissue and the blood vessels, and there is blood leaking and the exudate leaking everywhere. And then secondly, there is severe vasodilatation, and so blood pressure is not maintained correctly. So that is one function of the ACE2. The second function of the ACE2 is that it is immunomodulator. So keep this in mind, because this is one of the reasons that we have the issue. It is an immunomodulator. What does that mean? Is that it can change the immune system's response, and normally it dampens the immune system response. It dampens, it reduces. So now think about it for a second. When the virus, coronavirus, when the virus enters and connects with the, so I hope you all know that coronavirus binds with the ACE2 receptors. And after the binding, the virus and the receptor is internalized, right? So the virus goes in. So this receptor goes in as well. So that means, think about it, that means when the virus is present and it is being internalized inside the cell, in that process, the number of ACE2 receptors are also reducing. That means the function of the ACE2 receptors, which is an immunomodulatory function, which is to dampen the immune system, is reduced. So this is one way immune system's response or reduction in inflammation is stopped or halted or reduced by this crazy virus. So that's one. So not only it hijacks a cell, and it is actually taking care, it is taking the ACE2 receptors in the cell, which in turn are reduced on the surface of the cell, which in turn reduces their function in dampening the immune system. So that is one reason, ACE2 receptor reduction. Second reason, cytokine storm. And some people, not everyone, some people are experiencing cytokine storm by this virus. Now, let's understand what is a cytokine storm. What we know before this virus is that cytokine storms are done by super antigens. We do not know that if this virus is actually causing cytokine storm by being a super antigen, or does it have a different mechanism. I think that discussion will continue to happen as more literature is produced. So let me explain what is the cytokine storm, the second mechanism. In general, you can say there is huge amount of inflammation and activation of our innate and acquired immune system. Let me explain the standard cytokine storm, which may or may not be the right possibility here. We know that the cytokine storm happens in some people. We do not know the exact mechanism, so I'm going to provide you the regular mechanism. The regular mechanism is this. Imagine this is a T cell. This is another T cell. This is another T cell. They all can bind with various kinds of antigen. Every T cell has a T cell receptor that can bind to a unique antigen. This is why when the antigens appear, let's say a bacteria or virus, when that arrives in our body, normally one virus, so let's say this is a virus. I'm just going to make a standard virus here. So let's say this is a virus. When our antigen presenting cells eat up this virus, so let's say macrophage, when they eat this virus up, what will happen is they will break it down into smaller components, and then they will present those components up on their antigen presenting areas, or MHC2 we call them, MHC2 molecules. Then these macrophages bring these antigens to the T cells and B cells and other things, and they say, look, I have just killed this pathogen that had this antigen, let's say of this type. Would you mind helping me kill this antigen, this virus? And they'll say, yeah, definitely. And that one immune cell will become active. This lymphocyte will become active. Not all of them. Why not all of them? Because they all do not recognize the same antigen structure. Only one of them is recognizing it. This is possible that a virus or a bacteria would produce more than one kind of antigens, and maybe 2 or 3 or 4 or 10 types of T cells would become active, but not all of them. So when the T cell becomes active, what it does is it creates a lot of copies of itself. And then those copies, like an army, they go out in the body and start looking for these viruses and bacteria and antigens, and they start killing them. Yes, like a candy. That is absolutely correct. Right? So this is how normal function occurs. Now, there is a concept of super antigen. What happens in case of a super antigen is that the super antigen, if this is a macrophage, this is another macrophage, super antigen, instead of binding to the binding site, they bind on the outer side. They bind on the outer side and they just short circuit the T cell to the macrophage. They force them together even when that antigen is not of the type for the binding site. The result is a massive number of T lymphocytes will become active. They say that up to 25% of the immune system becomes active very quickly. And then these T lymphocytes in turn will make the macrophages active. They kind of potentiate each other's function or amplify each other's function. The result is a recursive loop where the immune system just keeps becoming bad and bad and bad. And it starts killing everything that comes in its way. So can you imagine? This is a cytokine storm. This is what happens, that a massive amount of immune system becomes incorrectly started. It was not supposed to do this. Only 2, 10, 20,000 T cells were supposed to be active. Now we have millions and billions of T cells active. That they are going to create cytokines, which are pro-inflammatory proteins. These proteins are going to call more cells to the area to cause destruction. Plus, they are very, very destructive to the tissue, to the blood vessels. The whole thing is going to become leaky and damaged, and there's going to be bleeding and exudates and edemas and blood loss, the fluid volume loss in the tissue, the dilatation of blood vessels, severe drop in blood pressure leading towards septic shock. So this is the second mechanism. In case of SARS-CoV-2, we do not know how does it exactly cause the cytokine storm. We do not know. What I taught here is the regular mechanism. When the literature evolves, we would know more that what would happen in that case. So this is cytokine. So the first ACE1 receptors, ACE2 receptors are reduced in number because this virus is using them to ship itself inside the cell. Second is that the cytokine storm is occurring. The immune system is active and it is just killing everything in its way. First, it is going to damage the lungs. Within 4 days to 6-8 days, it starts causing so much damage that 50% of the lung tissue is gone. And then it is consolidated. Then it becomes a scar tissue afterwards, and there is fibrosis. The tissue damage is extensive with this thing because of this rapid activation of the immune system. Third mechanism is the massive production of IL-1, IL-6, IL-12 in tumor necrosis factor and other cytokines. So let me explain what does that mean. Look, when the virus comes in, so let's say we have this silly, bad coronavirus. We don't like this coronavirus. I don't like it at all. So this is a bad coronavirus. He's trying to kill us and we're trying to kill it back. So let's say the coronavirus comes into our body. What happens is it is picked up by macrophages. Macrophages are the first responders of our innate immune system, our defense system, innate immune system. They digest it, so they internalize it, then they break it up into smaller pieces, and then they lay them out. So these are the smaller pieces, and then they present those pieces out on the MHC2 molecules. MHC2, they can present them out on MHC1 as well, but 2 is their primary function. And then in this process, and this, remember, MHC2 usage was over here, that we saw that they present it on MHC2, then the lymphocytes become active, and then the acquired arm of the immune system becomes active. So now, in addition to this, guys, this macrophage is going to release IL-1, IL-6, IL-12, tumor necrosis factor, and many, many other factors. We are concerned here with IL-1, 12, 6. What they do is, number one, IL-1, when IL-1 is released, it is pyrogenic. That means it produces fever. So one issue is that fever is produced, which is good. We want to know that fever is there, plus higher temperature helps kill the virus better. IL-6 does the same. It is also pyrogenic. It also produces fever. Then IL-12 is really bad because it would activate the T helper 1 cells. It would make naive T helper cells, 0 cells to T helper 1, which would activate cytotoxic T cells. So that is acquired arm of the immune system would become active. IL-1 also causes chemotaxis of other immune. It starts calling other immune system. IL-1 is like the loudspeaker that we use to call other people and say, please come here, work with us, we have a war going on. So IL-1 is going to call the neutrophils over there and the fibroblasts over there and other immune system to the area. And they are going to come and start causing lots of destruction. In that destruction, the lung tissue would be destroyed. Then they would spread in the whole body and destroy the blood vessels, organs. That would cause severe reduction in blood pressure, which in turn cause organ failure because organs are not receiving, they were not receiving oxygen before, and now they're not receiving nutrition because of low blood pressure. Renal failure would start, heart failure would start, other viscera and organs would start dying. Can you imagine how destructive this can be? This is not flu. Don't come to me and say, this is flu. This is not flu pathophysiology. This destruction, this massive destruction is just this virus. So we end up in a hospital in a serious state. There is so much of a chance that we end up on a ventilator, and from there, only 20% people survive. These are the reasons. So IL-1 is hugely chemotactic. It causes a lots of inflammation. Then IL-1, IL-6, and IL-12. IL-6 is so pro-inflammatory. You know, one of the ways they are controlling the inflammation by this virus is by suppressing IL-6. They are giving IL-6 inhibitors. They are giving IL-6 inhibitors to make sure that the inflammation is controlled. So this is the basic problem due to which there is extensive destruction. There is extensive destruction of the lung tissue and then possibility of the septic shock. So first there is destruction of the lung tissue, then the pneumonia develops. And please remember, in this case, it's a virus. Viruses usually cause interstitial pneumonia, which means the interstitium of the lung or the connective tissue of the lung or the spaces outside the gas exchange areas, they become sick first. But then it causes so much destruction that causes alveolar damage as well, and the pus formation too, and that becomes regular pneumonia. This is why when you do the chest x-rays and the CT scans, you see that first there are ground glass appearance, which is for the interstitial pneumonia, and then that converts into regular pneumonia appearance. This stupid virus is so bad. It starts that way, causes regular pneumonia, And then when the pneumonia becomes too extensive, inflammation is too extensive, that then goes, those cytokines go in the body, as I've said before, reducing the blood volume because the blood vessels are damaged, and there are exudates out of it. The fluid volume is getting out, reduces the volume. Secondly, cytokines cause the blood vessels to open up, which also reduces the blood pressure. And now we have low blood pressure, low blood volume, low oxygenation, low nutrition to the tissues. Tissues start dying. This is how these things are causing damage. So one, please understand how rapidly this kills. And secondly, why it kills. 3 mechanisms. And there may be more. So this is what I know so far. This is the literature. And even in this, the cytokine storm's mechanism is not clear. There may be more that would appear later on. People are not doing autopsies at this time. They're not looking into the lungs because of the fear that this would contaminate and cause infections to them. So we do not have a lot of understanding, and hopefully that would develop afterwards. So this is what I have. I wanted to make sure that we are aware for why this virus causes such rapid destruction and kills so quickly. Any questions? So, Carla, you were talking about pancreatitis. According to the WHO and according to the China's data, there is possibility of 3 to 4% of people to come in and present with gastroenteritis or GIT related issues instead of fever, cough, and respiratory system issues. So it is probably related to that. No, so we know that it goes from bats. We do not know the intermediate host yet. So this is the Anne's question, that have they decided what animal? What else? If you have a question that you wrote before, please write it again so I can answer that. Cynthia, bacteria plus a GMO modified? No, that's not. Lisa, that's not correct. Sir, is there any effect of ARBs or the basis of first mechanism? Yes, so ARB, let's talk about that. Do you want to talk about ARB? Do you have time? Very good. So Yusra is also asking what is the ACE receptor and ARB. So let's very quickly talk about the ARBs. Sorry, so I'm going to share my screen again, and I'm going to show you how the ACE inhibitors and ACE receptor blockers affect or not affect. So let's look at it. So first of all, I wanted to show this, this message by the HFSA and ACC. So this is American College of Cardiology. They have given out a statement on March 17, in which they have said, essentially, if we read from here, the continued, so let me put the question out first. The question has been that people, the folks who are on ACE inhibitors or on angiotensin receptor blockers, they are at an additional risk of death because this virus can upregulate the receptors. So this was a hypothesis by a study, and I have discussed that study separately. And so the American College of Cardiology came out and they said, no, this is not the case. Or they said, we are not aware, so we are not recommending that you stop using ASI or you stop using ARBs, or there is any additional risk. They have said, if somebody has that data, send it to us. We will do some more discussion and figure out if we have to change our statement. But at this time, that is the statement they have given. And I wanted to make sure that I explain why this statement. So let's talk. It's a very different topic from my original discussion, but let's look at it. We are saying ACE inhibitors and angiotensin receptor blockers, which are taken by folks who are diabetic or who are hypertensive. And they're saying that these people are at an increased risk. This is a very common statement out there. So let's see, there are both theories for it. I've already explained that there is a message from American College of Cardiology that this is not true, and they say we do not have enough data to say this is correct, and you continue to use those drugs, and If this is not true, if we found studies, we will then change our statement if we need to. But at this time, this is the statement to continue using these drugs. Having said that, let me explain the two theories. One theory that is pro ASI and ARB usage, and the other that is contrary or that is against the usage. So there are both studies out there. So let's see the pro study. Pro study says that here is a cell which has ACE2 receptors. And now if the ACE inhibitors or angiotensin receptor blockers, if they are sitting and occupying these receptors, then many of the ACE2 receptors are occupied. And the virus now has fewer number of receptors to bind with, so fewer viruses will be internalized, leading to lesser intensity of the infection. So this is one school of thought, which say that people who are using ARB and ASI are actually a little bit protected. The other school of thought, for which I actually have a study as well, I do not have the study for this one. If somebody has it, please send it to me. The other study that I have is a meta study which they did on multiple other studies. And that study said that here is a cell and it has ACE2 receptors. Now imagine if we are using ARB and ARB is blocking the receptor, or we are using ACE inhibitors, which in turn is blocking the drug, the chemical molecule in our body. So let's say this is the molecule this is the angiotensin 2 angiotensin molecule, which is going to be connecting here. And we have the drug that is kind of preventing this to connect here. In either case, the result is that this cell doesn't have enough stimulation to function from the ACE2 receptors or ACE1 receptors. The result is that the cell says, I am sitting here and I'm not doing a lot of function. Maybe that is because I do not have enough receptors on my surface, and that is because I'm not getting enough, due to which I am not getting enough stimulated. So maybe I should make more ACE receptors and put them on my surface so that I can be stimulated enough. So the cell upregulates, we call it upregulation. So cell upregulates the ACE2 receptors and ACE1 receptors and puts them on the surface. Now, according to this hypothesis, this is a hypothesis, there are more, the people who are taking ARBs and ACE inhibitors, they have upregulated ACE receptors. There is a greater volume or number of the receptors available, which are all now available to the virus to connect and internalize and cause infection or cause the replication in there. So this school of thought says there is an upregulation. American College of Cardiology came back and they said, we do not have enough data to say this is correct, so we do not ask you to change the drugs. So empathetic dreams of change, is there a precise dosage that works? So of course, the dosage that you are given by your doctor is calibrated to the need that you have. So that should be the precise dose. All right, so can they even cure viruses? I'm going to switch back to my camera. Can they even cure viruses? I can't think of one that they have. Well, curing viruses, there are some vaccines for the viruses. Then we have made HIV kind of a chronic disease. I think Corona might end up the first virus getting cured because of maybe hydroxychloroquine plus azithromycin plus other like zinc maybe. I have done a separate video where I have discussed those in detail. Please subscribe to my YouTube channel. Please join my Facebook page as well and see that I've done those discussions. Again, these are theories yet. We do not have the literature that is going to prove it 100% yet. When the literature comes out, we'll know more. But these are the theories. Okay, so then there should be a role of anti-cytokines to treat this. Yeah, that is why we have IL-6 blockers. That is one of the mainstay of this treatment. We have remdesivir. We have remdesivir to reduce the replication, and then IL-6 blockers are what we are using. Inhibitors are what we are using primarily when the people are on ventilators. IL-6 inhibitors. So yeah, anti-cytokines are very correct. Then there should be a role of anti-cytokines. So Najam, I answered that question. Most people are in hyponatremic dehydration. Amazing. And says malaria drug will kill. Hopefully, yes, and you're correct. FHS, what is the possibility of administering anti-inflammatory by inhalation to suppress cytokine storm? No idea. I would love to see those tests. I think that the medical community at this time is kind of hesitant to do too much tests on the people who are actually in dire state and may die. They can't do experiments, and we do not know the right strategies for management. So we're doing supportive management, and then whatever other test we can do without really risking the patients. How much would OTC, zinc, and arachidonic? I do not know, far from equilibrium. What is the right answer there? Reduce fever or not? Very good question. I think fever should not be reduced. If it is in low grade fever, 99.8, 100, 105, don't reduce it. It is going to help the body's immune system to fight with the virus. However, if it becomes cumbersome, if it becomes difficult, then you can, for the comfort, you can reduce it. But I would not reduce it if I'm there. And I would let that. Now, remember, with the fever, if you don't reduce the fever, what's happening is you are allowing the energy to be converted into heat. And that would mean that patient needs a lot of hydration and lots of food to make sure that they can keep producing energy. Problem is that we let the fever up, but we do not provide enough nutrition to the patient, or they cannot take enough nutrition. Resultantly, they start exhausting very fast, which can then cause immune system to start going down in its function. So if you want to keep the fever up, hydrate the patient a lot, and then make sure that they have good food so they have a continuous supply of energy that they're converting into heat. Plus, don't let the fever go up so high that it becomes dangerous. 104.5 and above can become dangerous in terms of coagulating the proteins and brain damage and so many other issues. So hopefully that answers your question. That is Carla. They need healthy volunteers. Yeah. Ziaullah says therapy. So I can't talk about therapy. I wanted to make sure that I talk about the massive destruction and rapid destruction that this virus does compared to other viruses or seasonal colds and stuff like that. Hopefully this is clear. Yeah, and I just said it. So when I said that high fever can cause coagulation of the proteins and damage to the proteins, that is when seizures come. But that is not 101. This is a viral disease. And viral issues, if there is no secondary septic infection or secondary infection, then the fever would stay low grade, Yusra, and that is not dangerous in terms of seizures. And then everybody's case is different. If somebody is already epileptic, try not to do this. We could hypothetically create free ACE2 receptors with no functionality. Absolutely, Alexander. That is a beautiful answer. Yes. We could create a bunch of ACE2 receptors and just inject them into the system and let the virus attack them and do nothing. Yes, they can actually act as like antibodies to connect them. I love it, Alexandros. Beautiful answer. Beautiful suggestion. Sir, what about using convalescent plasma? So I want to stop here because I don't want to prolong this video too long. The point was to talk about the inflammation. Tell me the topic for tomorrow. Maybe comment and tell me what topic would you like to do it. I would come back online tomorrow and we'll discuss those topics as well. Convalescent plasma is a huge and beautiful topic to discuss. Okay, guys. So thank you very much for joining, and see you tomorrow. We will continue to go live and we'll continue to do this. Good. So now I'm going to finish this. Thank you very much for joining. I hope you got something out of it for your time, and thank you for your time. Bye-bye. Okay. So put the comments for what topic would you like tomorrow, and I'll come in live and we'll talk about that. Thank you.